Buenas tardes a todos. Estamos transmitiendo un webinario más de la Asociación Mexicana de Ultrasonografía Crítica y Urgencias con su unidad de entrenamiento internacional en la ciudad de Guadalajara. Les pido disculpas por mi imagen, está un poco media rara, no sé por qué, pero de todos modos les agradezco mucho. Lo más importante es que podamos ver la transmisión con el doctor Pierpaolo. Y bueno, estamos verdaderamente muy contentos porque en esta ocasión tenemos un invitado muy especial, el doctor Pierpaolo DiNicoló, desde Imola, Italia. Él es nefrólogo y el tema que vamos a abordar en este momento es precisamente el uso del ultrasonido pulmonar en hemodiálisis, en este escenario en el cual muchos de nosotros desde luego tenemos y vemos pacientes, pero sobre todo el uso que el nefrólogo le puede dar. Como ustedes han visto, el ultrasonido point of care en general y el ultrasonido pulmonar en particular está siendo utilizado no solamente por el médico radiólogo o solamente el intensivista o el urgenciólogo, sino también ha abarcado otras áreas esta excelente herramienta, como es en cardiología, como lo hemos visto en otros webinarios en la ventilación mecánica pediátrica y ahora el uso del ultrasonido pulmonar en la nefrología, en los pacientes con hemodiálisis. Es verdaderamente interesante ver cómo poco a poco el ultrasonido ha tenido diferentes aplicaciones en diferentes escenarios y eso ha resultado una herramienta muy útil, como el doctor Pierpaolo menciona en sus trabajos que ha hecho, que es una herramienta, el ultrasonido pulmonar es una herramienta muy, muy poderosa que todos los nefrólogos deberían estar conscientes de ella. Y precisamente el doctor Pierpaolo, nefrólogo, pues tiene muchas publicaciones al respecto y sobre otros temas de gran interés y particularmente lo hemos invitado puesto que el ultrasonido y la aplicación en los pacientes con diálisis es algo verdaderamente muy, muy importante y muy interesante. Esta charla está basada en un artículo que publicó recientemente el doctor en una revista precisamente de nefrología, el Blood Purification, que trata una revisión sobre el ultrasonido pulmonar y de verdad estamos sumamente contentos y agradecidos de que el doctor Pierpaolo DiNicoló haya aceptado compartir su vasta experiencia, su conocimiento aquí con nosotros, con nuestra Asociación Mexicana en Ultrasonografía Crítica y Urgencias. Así que le damos la bienvenida al doctor. Gracias a todos los que nos están escuchando y viendo a través de Facebook o a través de esta plataforma. Sabemos que hay gente en otros países, en Latinoamérica, en Centroamérica, que nos hace el grandísimo favor de seguirnos, de darle like a nuestra página, de estar pendientes de nuestras actividades. Estamos muy, muy contentos y muy agradecidos. Sabemos que estos webinarios permanecen en la web, en nuestro sitio de Facebook y pueden después escucharlos, verlos con calma, transmitirlos incluso en una imagen, en un proyector, en un aula, en el carro, a la hora de la comida. Pueden disfrutar de los webinarios de manera detenida, tomando notas, viendo las referencias. En fin, esto ha sido para todos nosotros de gran utilidad, puesto que este conocimiento viene de los grandes expertos a nivel mundial. Así que, pues ojalá nos puedan decir de dónde cuando escuchen esta conferencia, aunque no sea en tiempo real, nos digan desde dónde nos escuchan. Eso nos encanta saber desde dónde nos están siguiendo. Y pues bueno, vamos a pasar a esta conferencia, que es propiamente la última de nuestra primera temporada de webinarios. Así que estamos muy contentos porque cerramos con broche de oro con el doctor Pierpaolo DiNicoló desde Italia. Como ustedes saben, en Italia se ha desarrollado enormemente esta tecnología, han desarrollado el ultrasonido pulmonar de una manera impresionante. Así que tener a los expertos italianos aquí en nuestra plataforma, en nuestra asociación de manera virtual ha sido increíble. Así que les invito a que disfruten de estas conferencias, de estos webinarios. Thank you so much, Pierpaolo. Thank you so much for accepting this invitation. There are a lot of people interested in your conference. Thank you for being part of this webinar, for enrich this initiative. We are really, really, really honored because you accept to be here in this initiative.
Thanks, Juan Antonio. It's a pleasure for me to be here. And I have obviously to thank todos los colegas y amigos de la Asociación Mexicana en Ultrasonografía Crítica y Urgencias. And I'd like to talk of lung ultrasound hemodialysis because as a nephrology, I currently work in the nephrology and dialysis unit in the hospital of Imola in Italy. And my areas of interest and research are mainly the clinical nephrology and the renal ultrasonography. So it's a pleasure to me to be here, so I can discuss a very interesting subject that combines both of these two aspects of everyday clinical practice. And the argument is the lung ultrasound in hemodialysis. As many of you already know, the stage renal disease is characterized by a profound impairment in the regulation of body fluid distribution. And the volume assessment in hemodialysis is one of the challenging goals for the nephrologist. Among other techniques, lung ultrasonography has attracted growing attention in dialysis for its supposed ability to detect the volume overload. So we'll take a cue from our recent work, and the purpose of this webinar is to clarify the physiopathological basis of lung ultrasound and its potential use in hemodialysis setting. So let's start with a summary. We'll talk about at first a brief history of comet tail artifacts. Then we'll talk about the extravascular lung water and what does it mean for a nephrologist, and the technical issue connected with the lung ultrasound, and what is the ideal weight, and how can we have an help by the lung ultrasound in hemodialysis. And another important issue will be the so-called hidden lung congestion. And lastly, we talk about the lung ultrasound, and we'll try to make a comparison between this technique and other volume evaluating techniques. So you know that the ultrasound techniques involve the passage of ultrasound from the probe through a series of physical interfaces that can be solid or liquid, and the presence of air prevents the transmission of the ultrasound waves. So until in recent times, the lungs were considered organs poorly or completely inexplorable with ultrasound techniques. However, all the pathological conditions that reduce the amount of air and conversely increase the fluid component in the pulmonary parenchyma make it amenable to examination by ultrasound. So as you can see here, in this case, the echography is not performed through the analysis of the morphology of the organ. It's not a real ultrasound examination, but it's a sort of study of the artifacts that the disease has generated. As you can see in this figure, the smaller the amount of the air, the greater the chance to appreciate the artifacts of lung interest. So we'll try to sum up some technical concept. Chest ultrasound can be performed with linear, cardiac, or convex probes with a range from 2.5 up to 7.5 megahertz. Harmonic or fundamental imaging can be used without important differences in terms of comets count. And it's also useful to set penetration depth at 4 to 8 centimeters, starting from the pleural line that you can see here. The focus of the image should be at the level of the pleural line to concentrate most of the energy for reflection. But as you can see in this case, it's not so important. You can always see the artifacts also if you have the focus more deep. And we can roughly recognize two types of reverberation artifacts determined by the lung surface. The first that you can see here is a ring down artifact that is called the A lines. And these are horizontal repetition artifacts without a precise clinical meaning in dialysis setting. But it's important to note that if you have the presence of both A lines and the pleural sliding, these two signs are enough to say that you have a normal lung. In this other slide, you can see which is the second and most important for us artifact, that is the so-called B line. You can see here a single B line starting from the pleural line. And the name at first was comets or comet tail artifacts, but now the common term, the most used term, is simply B lines that are vertical trend, have a vertical trend, and are of particular importance in situation of lung water overload. Now, with the chest ultrasound, the typical sonographic features of B lines are of laser-like vertical hyperechoic reverberations, originating from the pleural line and moving in harmony with the pleural sliding. Moreover, B lines generally are well defined and reach the bottom of the screen. In this example, you can see on the left a normal appearance of the lung surface with a clearly distinguishable pleural line, and B lines are absent. On the right, you can see that there is the presence of two B lines that are vertical reverberation artifacts originating from the pleural line. So it's interesting to note that we can really appreciate and find the so-called B lines. But curiously, though the clinical significance of a lung comet is well documented, their exact anatomic and physical basis remains quite uncertain. In fact, you know that the previously accepted theory was that the derivation of B lines was from subpleural interlobular septa thickened by the increase in extravascular lung water. But we have to say that now this interpretation is considered too simplistic, if not erroneous. And as you can see here, you can see a conference report of an expert panel, and they state that now is accepted that B lines do not have a specific anatomical basis. They could represent random internal reverberation caused by the interplay of interfaces among fluid-filled alveoli, or that can be considered the result of the change of water to air ratio per unit of insonated lung tissue caused by extravascular lung water expansion. Here in this slide, you can see this is the very first description of the comet tail artifact. This is a patient with a shotgun wound in abdomen, and you can see on the right part of the figure the X-ray that shows the lead pellets throughout abdomen. On the left, you see the grayscale ultrasonography scan of the right upper quadrant with the comet tail artifact beyond the pellets. You have here 3 B lines and 3 pellets. As you can see, distal to the lead pellets, a line of dense and continuous ecus is seen, and the aspect of this ecus is similar to that of a comet tail. This appearance was shown to be a reverberation artifact, and as the comet tail is function of the degree of acoustic impedance mismatch, you know that objects with different composition or whose sectional area is larger or whose acoustic impedance differ from that of their surrounding produce different pattern. Now, the clinical application of these comets, of these B lines, in the chest study appeared with the work of Liechtenstein, who found a strong association between B lines and clinical pictures of pulmonary edema. So chest ultrasound turned out to be a great tool for the differential diagnosis between cardiogenic dyspnea, and so alveolar interstitial syndrome, compared to that related to non-inflammatory chronic obstructive pulmonary disease. Another important point here, we have the evidence of a linear correlation between a radiological and ultrasonographic score of lung overload. So the B lines in this work became the equivalent of radiologic Carley B lines. In the first radiogram, you can see on the left of the slide, you have the clinical sign of the lung ultrasound, of the lung overhydration. On the right part of the screen, you have the ultrasound with the B lines. So in the next image, you can see the correlation between the radiological score of extravascular lung water and number of B lines here. And on the right side, you can see the correlation between the changes in the radiological score of extravascular lung water and ultrasound COMET score. So from here, we can say that we can use lung ultrasound to detect the expansion of extravascular lung water with a great correlation with the chest X-ray. And sometimes better. We'll tell this point, we'll underline this point later. Here we can see that lung ultrasound has a great sensitivity in providing a direct measure of extravascular lung water. And in this case, the estimation of overload, of lung overload, or lung volume overload, is analogous to the estimation of the thoracic impedance measured with an ICD, with great accuracy and precision, as shown here. And now we have to explain an important concept. What is indeed the extravascular lung water? Because the extravascular lung water is the key element for the lung ultrasonography, and is what lung ultrasonography can directly estimate. So extravascular lung water is the amount of water that is contained in the lungs outside the vascular compartment and within the lung interstitium. It derives from the balance of capillary, lymphatic, and interstitial oncotic and hydrostatic pressure. Physiologically, there is a normal leakage of fluid and solids from the pulmonary microvessel into the pulmonary interstitial tissue, but the volume of extravascular water generally is constantly controlled by the lymphatic drainage system. So every overload is removed by the lymphatic drainage system. But when you have a pathological condition, when you have a disease, this mechanism of compensation is impaired. Now, in this slide, you can clearly see the technique for the lung ultrasound that is used in the clinical setting, also in hemodialysis, and this is the so-called 28 rib interspaces technique, and is applied taking the probe in the intercostal space, and the search for B lines is performed through the exploration of various thoracic regions that are 16 on the right and 12 on the left, for a total of 28 scans. The scans are shown in the figure with the red dots, and you have here a three-dimensional CT of the thorax. On this part, you have the anterior-posterior view, and the probe is placed in this part. This is the parasternal line, and here we have the mid-clavicular lines, obviously in both the hemithorax. In this part, you have the right lateral and the left lateral view. And here, the transducer is placed along the anterior and mid-axillary lines. So all the scans goes from the second to the fifth intercostal space on the right, and from the second to the fourth intercostal space on the left. With the lung ultrasound, you can obtain a quantitative or semi-quantitative evaluation of the interstitial lung water, and you can count the B lines in each intercostal space, and finally, you can make a score that is the component of the sum of all these B lines. So you can say that the score is considered absent or mild when up to a total number of 15 comets is detected, moderate from 16 to 30 comets, and serious if you have a number of B line observed that exceed the number of 30. So if you have the interstitial syndrome, is defined by the presence of bilateral, multiple, and diffuse bilines. Now, a brief explanation of the general advantages of the lung ultrasonography. Obviously, the non-invasiveness, the free from radiation, the acceptable intra and interoperator reproducibility, and its easy of use are among the most important part. And now the fact that you have a lot of portability ultrasound devices make this technique very interesting. Another important point that we have to underline are the disadvantages, and you have to consider that chest ultrasound can be difficult if you have the presence of large dressing for possible subcutaneous emphysema and for soft tissue swelling or obesity. So you have always to remember that the lung ultrasound has great sensibility, but not great specificity. So we are very sensible in discovering, seeing, and counting the comets, but we cannot say which is the cause of extravascular lung water or the underlying disease. So if you have diffuse parenchymal lung disease, such as pulmonary fibrosis, systemic sclerosis, or if you have a focal multiple bilines pattern, you can have conditions such as pneumonia, pulmonary infarction, pleural disease, and neoplasia. So in all these cases, you need a medical history, you need a clinical picture of the patient in order to analyze and interpret the ultrasonographic data. Oh, now we'll talk a concept that is very important for the nephrologists that are used to it, and that is essential for the tailoring of the hemodialysis session. Because, as we already said, the end-stage renal disease is characterized by a profound impairment in the regulatory system of body fluid. So the target of hemodialysis is not only to remove uremic toxins, but you have to restore sodium and water balance. You have to take the patient and get him to an ideal weight. This ideal weight is called the dry weight because, as you know, the patient generally has no diuresis. So what is this dry weight? And there is no universally agreed upon definition, but according to one of the most important authors, we can say that it is the lowest tolerated post-dialysis weight achieved through a gradual change in post-dialysis weight, and at which there are minimal signs or symptoms of either hypovolemia or hypervolemia. So as you can see, the dry weight concept is acknowledged to be a rough surrogate for euvolemia. Okay, as you can see here, in chronic hemodialysis patients, you have a bidiurnal variation of fluid status. Between two subsequent dialysis sessions in the interdialytic period, the patient gains weight because of fluid retention. This excess of water volume will then be removed here during the next dialysis session with ultrafiltration. So you can ask why achieving the correct dry weight is so important for hemodialytic population. Because acute or chronic volume overload are very frequent in hemodialysis, and this carries important aftermath in terms of survival. In fact, volume overload is directly associated with hypertension, increased arterial stiffness, left ventricular hypertrophy, heart failure, and higher mortality and morbidities. In this slide, you can see the other ratio of all-cause mortality for interdialytic weight gain when this weight gain is above 1.5 kilograms or liters. And you see that the higher interdialytic weight gain is associated with poor survival and increased cardiovascular death. So it's very important to arrive to the correct dry weight. It's a difficult but fundamental purpose. So therefore, if we want to avoid volume overload, we have to determine the euvolemic status and using a combination of different techniques. So as you can see here, the history and physical examination is only a part of this evaluation. This is the so-called 5B approach proposed by Rosner and Ronco. It is very interesting because the real dry weight of the patient is a sort of final result of different components. And among them, you have the blood volume online monitoring, the bioimpedance, we'll talk about this part, about this technique, the beat natriuretic peptide, and the body ultrasound. With body ultrasound, we refer to inferior vena cava diameter measure and the lung ultrasound. So, as I have already anticipated, lung ultrasound has been widely validated as an additional tool in the field of cardiology and for cardiogenic pulmonary congestion. Sometimes is a compendium to echocardiography. And another important point is that the presence of multiple B-lines is the sonographic hallmark of lung edema, and a negative lung ultrasound is superior to standard chest X-ray in excluding significant pulmonary water overload. So, using this ability to accurately estimate the extravascular lung water, the modern lung ultrasonography has extended its field of clinical application from cardiology and intensive care setting to hemodialysis, where it has been proved to be useful and easy to learn. As you can see in this slide, a very important point, a very important element connected with the lung ultrasound in hemodialysis is that it has the ability to detect and estimate the degree of extravascular lung water in a dynamic way. So you can see that there is a quantitative reduction of B lines that can be appreciated in real time during the dialysis session and in proportion to volumes removed by ultrafiltration. So you see that the comets, the B lines, disappear in real time when volume is removed. In particular, a decrease of 2.7 B lines for every 500 milliliters of volume removed can be seen. And the B lines may be an early marker of extravascular lung water before dyspnea appears. And another important point is that thanks to all these abilities, lung ultrasound can be an ideal tool to estimate the ideal body weight, so the so-called dry weight in hemodialysis. And the fact that you have a dynamic variation of B lines during hemodialysis session can be seen also here, when you see that in all these scans, you have a 28 approach here. You can see that in every region, in every scan, there is a pre and post analysis, and you can see how the B lines disappear during the dialysis session with fluid removal. And of interest, the patients with higher B lines score after dialysis were more likely to be hospitalized for pulmonary edema or acute coronary syndrome. So it's important to remove the B lines during the hemodialysis session. Now, you can see here, I don't know if it starts, we have two examples of lung ultrasound scan before and after hemodialysis session. This is a patient, this is a man in my unit. And you can see here, there are 3 or 4 B lines that clearly can be seen here. But after hemodialysis session with an ultrafiltration about a total of 2 liters, if I well remember, you have no more B lines. So we have now to talk about a very important issue, that is the hidden lung congestion, or if you prefer, congestion pulmonar occulta, and a state of a chronic volume expansion of a variable degree is very common in patients with renal impairment. And the frequency of this so-called hidden lung congestion has been shown in this population of 88 peritoneal dialysis patients. The lung ultrasound notes the mild to severe pulmonary congestion in 46% of the patients, and among them, about 57% had no dyspnea. As you can see here, they can be classified as New York Heart Association classification, functional class 1, so completely asymptomatic. But as you can see here, the number of B lines is elevated. Another example comes from this work on 51 peritoneal dialysis patients, and in which you can see that there is an impaired physical activity in about 80% of this population. That here is evaluated with the steps per day. But the important point for us connected with the hidden lung congestion is that 39% of the patients had moderate to severe lung congestion, and 55% of them 55% had severe pulmonary congestion and were classified as functional class according to New York Heart Association 1, so without dyspnea. Finally, we can see this work on hemodialysis patients. These are 270 hemodialysis patients, and the 58% had moderate to severe lung congestion, and 38% of these patients were completely asymptomatic. So what we can assume? We can say that regardless of the type of dialysis population considered, so at first we have seen the peritoneal patients and then hemodialytic patients, the asymptomatic pulmonary fluid overload is often present, and as it remains silent, it can over time have a negative impact in the quality of life and survival of end-stage renal disease patients. In this case, I have presented a 70 years old woman, that is a hemodialytic patient, without dyspnea or fatigue, with a normal chest X-ray examination, but with clear sign of extravascular lung wall expansion, as you can see here with all these B lines. And probably, if you at your center try to verify this concept, you can be surprised by the diffusion, by the importance of the so-called hidden lung congestion. And why? Why the hidden lung congestion can be so diffuse, can be so important in this population, in end-stage renal disease patient? You have to consider that there are two important elements. I'll try to explain the first, that is the cardiac function. So the left function in particular is the first element. As is shown here, you have in end-stage renal disease a lot of impaired function. So the uremic heart has abnormal cardiac energetics, has disordered of myocardial calcium utilizations, and in general, uremic hearts have increased susceptibility to ischemic damage. This is an experimental animal model, but the lesson is clear. So there is a clear left ventricular dysfunction when you have end-stage renal disease. And it's generally accepted that about 30% of patients entering chronic dialysis show frank symptoms of heart failure. In this study, up to 48% of asymptomatic patients stabilized on dialysis have compromised left ventricular function, and in this case was evaluated mainly by alteration in the ejection fraction. And you can say all these patients were asymptomatic. So we can assume that the left ventricular dysfunction with its related increased cardiovascular risk is frequent in hemodialysis patients and often in an asymptomatic way. In this study, we have 75 hemodialysis patients in which lung water was strikingly increased in the vast majority of symptomatic and asymptomatic dialysis patients. And lung water appeared strongly associated with altered left ventricular performance measured by left ventricular ejection fraction. And you have the pink circles that are the pre, and the green circles are the post dialysis lung comets. So you can see that there is a strong relationship between these circles, pink and green, with the left ventricular ejection fraction. We have explained the role of the left ventricular ejection fraction, but it's not only this element that is important, because other parameters of left ventricular function, such as left atrial volume and lung pressures, are strongly related to the findings of lung ultrasonography. Therefore, the strong sensitivity of lung ultrasound for the early detection of pulmonary congestion in dialysis patients, especially when associated with reduced physical function, as we have already seen, could partly derive from the pathophysiological correlation between lung ultrasound and functional disorder of the left ventricle. Here, you can see in this work by Balamachi that we can better appreciate the relationship between B lines and pulmonary pressure, or to left ventricular filling pressure in dialysis patients. As here is clearly shown, extravascular lung water can be strictly correlated to pulmonary pressure or to left ventricular filling pressures. And with the escalation of the degree of pulmonary edema, the number of B lines can rise proportionally. However, we have to be precise. You can have a connection between B lines and this pressure, between lung pressures of the left ventricular filling pressure. But this correlation is not exclusive. And in end-stage renal disease patients, it's possible to obtain increasing comets even when pulmonary pressures are normal or near normal, so without hemodynamic congestion. In these cases, probably the pivotal role for increased extravascular lung water is played by the augmented pulmonary vascular permeability. So, at first, we have explained the role of uremic heart. Now, we have to talk about the uremic lung. In fact, besides the left ventricular function, the augmented lung permeability should be considered. In fact, renal failure can greatly affect distant organ function, and the uremic lung is a complex entity that has been studied mainly in the acute kidney injury setting. However, many observations derived from this study can probably be extended to end-stage renal disease and to hemodialysis setting, because we have the production of pro-inflammatory and pulmonary permeabilizing cytokines, such as interleukin-6, that greatly increases in severe chronic kidney disease. And we know that this kind of interleukin, but also other mediators, are central regulator of the inflammatory process, and they mediate increased lung permeability in mouse model of acute kidney injury. There are also other elements that you can see here. For example, the leukocyte trafficking and the dysregulation of lung salt water channel that all contribute to the uremic lung and to the presence of augmented lung permeability. And finally, to the appearance of B-lines. I like this slide because in this slide we have tried to sum up all these physiopathological concepts. As you can see here, this is only a proposed physiopathological sequence in which we have mainly heart impairment and here, and lung increased permeability here, which determine extravascular lung water expansion. And at first, with this expansion, you have the appearing of B-lines, and from the clinical point of view, you can have a patient completely asymptomatic. You can have a patient with a class in New York Heart Association class function 1, classified as 1, or you can have a reduced physical function, but you have no dyspnea here. You have extravascular lung water expansion, but no dyspnea. But if this kind of expansion increases more, finally you have dyspnea, you have a clinical appearance, and obviously you have an increasing number of B-lines. As you can see here, the systemic circulation, the systemic fluid overload is not directly correlated with extravascular lung water. Okay, this is an important point, and I'll explain this point later. So here we have the hidden lung phase. With the progression of a lung interstitial syndrome, we have the transition from the preclinical to clinical phase. And together with it, we have the quantitative B-lines increasing. Now it can be interest to ask if we want to compare lung ultrasound to other techniques, how does lung ultrasound perform? If compared to other techniques, useful in hemodialysis to assess the volume, to assess the correct dry weight of the patient. So if we compare lung ultrasound with the classic sign of fluid overload, you see that lung crackles and peripheral edema, we note that there is not a great sensitivity for the clinical evaluation. On the other side, lung ultrasound revealed pulmonary congestion in a lot of the patients of this study. For example, here we have lung ultrasound that revealed pulmonary congestion in about 65% of the patient, while the clinical signs were helpful only in 21% of the patients. So we have a great sensitivity for the lung ultrasound, a very reduced sensitivity for the clinical evaluation. So lung crackles, for example, either alone or combined with peripheral edema, very poorly reflect interstitial lung edema in patients with end-stage renal disease. In figure, you have a clear demonstration of this aspect. And this is not an isolated conclusion. So when we rely only on the clinical evaluation, probably we are not making the correct thing for our patient. For example, in this study, we are not talking about hemodialysis patient. We are talking about an heart failure setting, which were patients with heart failure here were subdivided for a number of B-lines, and only 19% of these patients in the highest tertile had crackles on auscultation, confirming the ability of lung ultrasound in detecting subclinical congestion. Moreover, an elevated number of B-lines had a great importance for risk stratification, as you can see here, because a higher number of B-lines identified patients with a 4-fold risk of heart failure, hospitalizations, or death. from any cause in the subsequent 180 days. It's important to underline here that there is a discrepancy, a great discrepancy between clinical sign of volume overload and lung ultrasound score. The question could be why, but probably if we consider that all the pathophysiological aspects that we have already explained, probably we are not so surprised. But it's important to say another important aspect that lung ultrasound is strictly connected to all the physiopathological factors that can increase extravascular water. So its sensibility probably is one of the greatest among the techniques that we have. And this is not the case of the clinical evaluation. But this peculiarity of the lung ultrasound, this ability to have a focused vision of the extravascular lung water, indeed, is also the limit of the lung ultrasound, because as we have already anticipated, lung ultrasound cannot directly evaluate systemic fluid volume. In other words, it's unable to provide information on the total body volume status of the patients. We have to be aware of this limitation. And here you have a classic example of bioimpedance spectroscopy. That is a non-invasive technique that can evaluate the body hydration status. That is important because it has been validated by isotope dilution methods. So it's an important technique. It's a useful technique, and it's non-invasive. And it also provides information on fat and the lean tissue composition. And this is a promising method that objectively defines the individual overhydration status, taking into account the individual body composition. So a comparison between lung ultrasound and bioimpedance is obviously important for us. Here you can see that with a bioimpedance device, we can have a quantitative determination of hydration status and of its deviation from normal range. We have this region, that is the N region, that defines a healthy population, established with data from a previous study based on more than 1,200 healthy Caucasian subjects. So we have a validated technique, and this plot defines the normal hydration range that, as you can see here, is between minus 1.1 and plus 1.1 liters, taking into account fluctuations from daily activities. So we have over or under hydration in normal subject. Here we have the hemodialysis patient, which can obviously range in a more larger plot. And we can, with this technique, define a quantitative determination of fluid overload. So we were talking about the comparison between the lung ultrasound and bioimpedance. And it appears that there is a good agreement between these two techniques. And in this study, body bioimpedance spectroscopy was compared with ultrasound and also with other techniques, and you can see that there is a good agreement in these two figures, and you can say that the results show that B lines are positively related to bioimpedance derived fluid overload, and that this association is stronger on the pre-dialysis evaluation. And in this case, not only B-line score has been confirmed to be closely related to the data derived from total bioimpedance analysis, but also to that of focused thoracic bioimpedance analysis. So lung ultrasound here was validated as a tool for an effective bedside estimated of pulmonary congestion in hemodialysis patient. And you can see here that there is the decrease in number of B-lines post-hemodialysis. This is an aspect that we have already explained. And on the right side, we can see that there is, during the dialysis, an increase in thoracic impedance that in its and this fact is indicative for a decrease in lung water content. Now we can make a clear comparison between the advantages and disadvantages, the pros and cons of these two important tools that are lung ultrasound and bioimpedance. So as you can see here, lung ultrasound is focused on extravascular lung water, while the bioimpedance, as we have just said, can give a quantitative and precise information on total body water. These are two good techniques because they had low cost and can be performed bedside. But lung ultrasound can do an intra-hemodialytic evaluation, while with bioimpedance this cannot be made. And we can also have with lung ultrasound an immediate post-hemodialysis evaluation, and this is not possible with bioimpedance. We have to wait for about 2 hours, and we have a great reproducibility between these two techniques. Obviously, we have the limits that with lung ultrasound you have to have a small knowledge of the ultrasound machine. So you have the operator has to have some skill, although quite a simple examination to learn and perform. And I want to show you this work that is an important review recently appeared on the American Journal of Kidney Disease, in which we have this suggestion, this interesting suggestion from the authors. And they say that at this time the lung ultrasound should be used in addition to bioimpedance only for dialysis patients with compromised cardiac function, whereas bioimpedance is probably sufficient for the rest of the patient with end-stage renal disease. I think that this point may deserve a more in-depth discussion from the listening colleagues at the end of the presentation. And only 3 studies have compared lung ultrasound with inferior vena cava measuring diameter, and results are indeed quite heterogeneous and conflicting. But if we want to synthesize, we can say that the inferior vena cava diameter reflects fluid status, but only in a pre-dialysis evaluation. So the inferior vena cava diameter has modest sensitivity for detecting changes in fluid status after hemodialysis. And in this specific setting, it has proven to be inferior to lung ultrasound. And another important issue I want to underline here only briefly is that extravascular lung water measured by lung ultrasonography is an important tool to assess and predict the potential deleterious impact of occult overhydration in hemodialysis patients. As you can see here, we have 96 hemodialysis patients who were tested in order to understand the prognostic value of lung ultrasound comets. And as you can see, the lung comet score emerged as the best predictor for hydration status related mortality, independently of bioimpedance derived parameters. You have here a Kaplan-Meier survival analysis, and it's clearly shown that when you have an upper B-line score, you have an elevation, an increasing mortality. There is probably only one point that we have to analyze. So we know that lung ultrasound can be useful in detecting extravascular lung water expansion both in case of increased lung permeability and underlying cardiac dysfunction, regardless of systemic volume overload or presence of symptoms. But what is far less clear is whether lung ultrasound can assume a pivotal role in the clinical management of the dialytic session. And now, at present, a multi-center clinical trial in hemodialysis patient with heart disease, that is the LUST trial, is underway in order to answer this clinical question. You can see here the inclusion criteria of this trial and exclusion criteria. As you can see, patient with are included patient with history of myocardial infarction or heart failure. So it will be an important test for the lung ultrasound in hemodialysis. If we want to conclude, we can say that the chronic volume expansion is common in renal disease and is often asymptomatic. In end-stage renal disease patient, the extravascular lung water expansion is mainly determined by heart dysfunction and lung permeability. Lung ultrasound can directly evaluate extravascular lung expansion. So it's great, it's useful. But, and moreover, lung ultrasound can evaluate extravascular lung water in a dynamic way. So during an hemodialysis session and just at the end of hemodialysis session. But we have to remember that the lung ultrasound has a great sensibility, but poor specificity. So the lung ultrasound evaluation can make only an indirect evaluation of total body fluid, and lung ultrasound can help to define the correct dry way, mostly if combined with other techniques. And in this case, it is a good prognostic indicator for cardiovascular morbidity and mortality in hemodialytic patients. Thank you. Gracias a todos.
Muchas gracias. Thank you so much, Pierpaolo. We are really, really excited for your presentation. It's a very, very nice presentation. Thank you so much, Pierpaolo. We are really, really excited. We have seen a huge and fantastic journey through the V lines and the extravascular lung water and the usefulness of lung ultrasound for the nephrologists and for everybody and all the physicians who are involved in the treatment of dialysis patient or even in emergency room, etc. I will speak in Spanish for a while, if you allow me, Pierpaolo. Chicos, pues como ustedes han visto, estamos ante una presentación increíble del doctor Pierpaolo, al cual le agradecemos muchísimo haber aceptado esta invitación. Hemos visto cómo el doctor nos ha explicado con un detalle increíble y un viaje a través de la literatura, cómo el ultrasonido pulmonar tiene una excelente utilidad en los pacientes de nefro, en los pacientes con insuficiencia renal crónica terminal. Y sobre todo, aquí es bien importante que me gustaría comentar algo en español, que quizás no todos los médicos que tenemos a nuestro cargo pacientes críticos o en áreas críticas, quizás podamos o estemos entrenados para realizar un ecocardiograma avanzado en el cual podamos determinar y evaluar las presiones de llenado en una forma correcta. Sabemos que esto, no todos los médicos han podido ser capacitados en este tópico. Sin embargo, el ultrasonido pulmonar, debido a su corta curva de aprendizaje, debido a su accesibilidad, debido a su gran utilidad, creo yo, y ustedes estarán de acuerdo, que es imperdonable que un médico que está tratando pacientes críticos o en áreas críticas, llámese quirófano, unidades de diálisis, unidades de urgencias, terapias intensivas, no sea capaz de al menos utilizar el ultrasonido para la evaluación pulmonar. Como ustedes han visto, podemos o no estar capacitados para evaluar presiones de llenado, pero con ultrasonido podemos evaluar el agua extravascular pulmonar, que como ustedes han visto a través de la literatura que el doctor Pierpaolo nos ha mostrado, está directamente relacionada con el pronóstico de los pacientes. Ya vimos que no solamente en los pacientes críticos, sépticos, cardíacos, sino también en los pacientes con enfermedad renal, por lo cual resulta todavía aún más útil y más interesante el ultrasonido pulmonar. Ahorita vamos a pasar a los comentarios que nos están haciendo, pero bueno, simplemente comentar pues que ha sido de verdad un placer escuchar al doctor, sobre todo respecto a cómo el ultrasonido puede detectar en forma oculta la congestión pulmonar, incluso en etapas preclínicas. Eso lo hemos ya visto a través de los estudios que varios cardiólogos han hecho, como la doctora Luna Gargani, como el doctor Platz, que vimos sus diapositivas, etcétera. Nos han mostrado cómo el ultrasonido pulmonar puede detectar en fases preclínicas a los pacientes de verdad sobrecargados de líquidos. Y pues bueno, por aquí hay un comentario, vamos a escuchar, le vamos a dar audio al doctor, hay dos panelistas que quisieran hablar. Huawei P10 Lite, si te quieres presentar, doctor Huawei, yo creo que es la marca de tu celular, pero no sé si quisieras hacer algún comentario o alguna pregunta, doctor.
Hola, ¿qué tal? Pues es muy interesante lo que mostró el doctor. ¿Qué tan seguido realiza el ultrasonido pulmonar en una condición de hemodiálisis crónica? How often do you perform lung ultrasound in a chronic condition treated in hemodialysis? Thank you very much.
Gracias.
Thank you. Thank you for the question. This is a good question, because before this webinar, I was talking with Juan Antonio, and we were talking about the importance of doing the ultrasound examination for our patients. And I use very often the lung ultrasound for my patient, because I use all the other techniques too. I have the bioimpedance machine. I have to do the clinical examination, but the lung ultrasound has something more, in my opinion. Above all, for chronic patient on hemodialysis that has a valvular disease, because obviously I could not explain this aspect during the webinar in order not to be too long, but when you have a valvular disease, you see that the bioimpedance cannot be so useful, because you can have a patient with a dry weight that is not the one indicated by the bioimpedance. Because if you make your lung ultrasound examination, you see that there are a lot of B-lines. And for the bioimpedance, the dry weight perhaps is correct, but it's not correct for you, because you know that if you have a valvular disease, probably that patient has a fluid overload, not in the systemic compartment, but only in the lung compartment. So you have to treat the patient and probably increase the ultrafiltration. So I think that this is only an example, obviously, but I think that the focus, the division of the lung ultrasound for hemodialysis is extremely precise, and it can give precise information on particular patients. And every one of us, every nephrologist knows that in hemodialysis patient, in chronic hemodialysis patient, you have complex patients. And sometimes the clinical evaluation or the bioimpedance are not what we need. We need to know where that patient has to be taken, where we have to take his ideal weight, his dry weight, and it could be less than one indicated by impedance. For example, in this example I have made. I don't know if I have explained well the concept.
Yes, thank you very much. You were very
clear.
distracted with us. Thank you.
Ok, gracias,
Thank you for the
doctor.
question.
Gracias, doctor. No sé si tuvieras otra pregunta, la puedes hacer. Por aquí parece que hay otro médico que quisiera decir, parece que no hay otra pregunta. Ojalá que pudieran hacer sus preguntas. Parece que el doctor César, efectivamente, el doctor César quiere hacer una pregunta. César, adelante, te escuchamos, doctor. Gracias por estar aquí. César, ¿puedes hablar? Ok, parece que no. César, ¿nos escuchas? Bueno, parece que había levantado la mano, pero a ver, vamos a ver. No, parece que no. César, ¿nos escuchas? Bueno, quizás se equivocó. No parece que no. Well, Dr. Pierpaolo. Well, in my opinion, this is very, very important, Pierpaolo, about the treatment, how to use the lung ultrasound to guide the treatment, because apparently the last study is trying to answer this question. And I'd like, Pierpaolo, if you can explain a little bit more about how to guide the treatment by using lung ultrasound, because I think that maybe most of the people are interested specifically in this question, how to guide the treatment. I mean, is it useful? We can use the lung ultrasound before hemodialysis if you have an outside patient, an out hospital patient, and you see B lines, you have to optimize your treatment, or what is your opinion about this, Pierpaolo?
I have to thank you for this question because it's one of the elements I'm trying to improve best. Now, in my experience, I am trying to use lung ultrasound for tailor the diuretic therapy in pre-dialysis, so in end-stage renal disease, but not on dialysis. Because, as I have already shown, you can also use this technique when you have a reduction, a great reduction of the glomerular filtration rate. You can try to use lung ultrasound. Obviously, we have to be very careful in the sense that, as I have said, we have no, at the moment, the proof that you can guide the therapy with lung ultrasound. I think that it will not be difficult to be validated, but at the moment we have not a final proof. But if you use the lung ultrasound hemodialysis, I talk about my experience. When I use lung ultrasound hemodialysis, I try to tailor the therapy in this way. What I want to do is not to achieve a dry weight that I don't know. What I do is try to less the dry weight slowly, without run. What I want to do is not to incur in hypotension. I don't want to have cramps, so I can use the ultrafiltration in a slow way. If I have a certain number of B lines, if I have a mild presence of B lines, probably, and this is in a pre-dialysis stage, probably my dry weight is correct. But if I see that after dialysis I can make a lung ultrasound and my patient has a lot of B lines, probably I am not in a right direction. I have to increase the ultrafiltration slowly along the subsequent sessions, about 300 milliliters for session, but I can go on slowly. And if I remember well, in the LUST study, the variation of the ultrafiltration was 300 milliliters per week. So as you can see, the reduction of the dry weight was quite low, was small, because indeed, lung ultrasound is not useful to have a rapid variation. What we want to do is achieve a gradual reduction. Okay, I have answered to your question, Juan Antonio. It's correct.
Thank you. Yeah, of course, Pierpaolo. Thank you so much. It's very, very clear. Actually, there are some questions, and I'll speak in Spanish, and then I'm going to translate you, Pierpaolo, if you allow me. Bueno, empezamos por la pregunta de Arnulfo. Nos está preguntando si se puede evaluar en pacientes que van a trasplante renal en la etapa pretransplante y o post-trasplante y cuál es su impacto en el pronóstico. Pierpaolo, one doctor is questioning about if lung ultrasound is useful to evaluate the renal patients in previous to transplantation and after renal transplantation. What is the impact in the prognosis of these kind of patients, evaluating them with lung ultrasound, Pierpaolo?
This is an extremely great question. I have to say that this is a very interesting question, but at the moment we have no data that I know about this argument, and probably it will be great to test the lung ultrasound for this kind of population. But at the moment we have no data on this argument. But in my opinion, the problem now is not if lung ultrasound is useful in all the kind of renal pathology, and we have to include, in my opinion, the transplant, the renal transplantation. The question is not if the technique is useful, because the technique is useful. I think that we can use lung ultrasound for that kind of patient, but we have to correctly interpret, to correctly understand what we are doing. So we cannot use the lung ultrasound without other techniques, as I've already said. If you try to make a 5B approach for patient with end-stage renal disease, probably we have more probability to arrive to the correct therapy.
Right.
Okay.
Maybe this is the key point, right? The key point, because we can arrive with the best therapy. Okay, it's excellent. Thank you, Pierpaolo. There is another question. César dice, gracias por su excelente plática. En el puntaje que nos presentó de la severidad, el líquido en el intersticio pulmonar, ¿cómo cuantifica las líneas B? Es decir, mide el número de líneas B en cada punto donde se coloca el transductor y después se suman. This question, Pierpaolo, is specifically about the B lines counting. You know, it's a very interesting because there are a lot of studies ongoing about this. But what's your opinion about this question? How to evaluate the B lines in our patients?
I have I can use if you want my presentation, and in order to achieve this one, just okay, this one. As you can see here, the number of B lines is indicated as a score, and under 5 B lines, indeed, you can say that there is an absent expansion of extravascular water. While when we arrive at this count, we are talking about a mild and moderate degree expansion, and above 30 B lines, we have a severe degree. If you want to count the B lines when you make your examination, you have to make a small video of 3 to 4 seconds is sufficient, and basculating the probe, you can see the greatest number of B lines for that scan. And finally, at the end examination, you can play again all the scans, and you can count with more precision the B lines. Obviously, this is valid if you can see the B lines, if you have a clear vision of the B lines. But sometimes you cannot see clearly all these B lines. Also with the video is not possible. In these cases, probably you have to make a percentage of the B lines. So roughly, you can say that if you see I want to explain. It's not easy. So if you have a confluence of B-lines, you can use the percentage of the reef space covered by the B-lines and divide for 10. Okay, so you have, in other words, if you have in this image, for example, a confluence B-line that covered the 30% or the 80% of the image, you can say that you have 8 or 9 B-lines.
Right.
It's clear my explanation.
Yes, of course. Yes, of course, Pierpaolo. Actually, your Italian is very similar to the Spanish, so we really understand. Really, thank you so much. Well, there is another question for Hawei. It says, intradialytic weight gain has a correlation between the number of bill lines. I mean, once again, intradialytic weight gain, does it has a correlation between the number of B lines, intradialytic weight gain, and the relationship?
I think that it's a good question, but I think that you are not looking in the right direction. Follow me. If you have a great weight gain, not necessary you have increased B lines, because as I've said, with the lung ultrasound, what you see is the number of B lines, and you see only the lung compartment. You can have a patient with 3 to 4 kilograms in the interdialytic period, but without B lines, because the question is if this patient if he has the two components which determines the expansion of extravascular lung water. Okay, so if you have no heart, a uremic heart, and if you have not a clear uremic lung, you can have a patient with an increase in the weight, a small, for example, or a mild increase in the weight, without a clear expansion of extravascular lung water. Okay, so I think that when you make a lung ultrasound, you see only a piece of the problem. So perhaps sometimes you cannot have this strict connection, or you cannot have always this connection between the B lines and the interdialytic weighing. Because if you have a patient, for example, which weighs 100 kilos, and he interdialytic weight takes 3 kilograms, okay, you can have at the lung ultrasound perhaps nothing.
Right.
Are you understanding what I'm saying?
Yes.
You cannot make with the lung ultrasound an absolute vision of the weight. For this reason, I've said that you have to combine lung ultrasound, for example, with bioimpedance.
Yes.
Okay.
Right. I know.
So I can have, for example, and this is a paradoxical problem, but I think that this fact answer better to the colleague. You can have a patient with 1 kilograms of interdialytic weight and a lot of B lines. And if we know that there are no confounding factors, for example, there are no pneumonia, there are no neoplasia of the lung, and so on, you understand that this patient probably in only 1 kilograms has a lot of problems. Okay, because he has the uremic lung, or he has the heart, the uremic heart, and you have to correct his volume status with ultrafiltration. Okay.
Right. Thank you so much, Pierpaolo. And actually, we have to take into account that the lung ultrasound is able to measure the extravascular lung water regardless the capillary pulmonary wet pressure, because sometimes the patient has, for instance, a high pulmonary wet pressure, and not necessarily the patient has a huge amount of extravascular lung water. This is similar. Maybe the patient has he has a lot of weight, but the patient not necessarily has a huge amount of extravascular lung water. Is it right?
Yes, 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 yes,
Yes.
yes,
Okay.
yes.
Mhm.
The problem is that as a nephrologist, sometimes we tend to in absolutization of the concept of dry weight. As I've said, dry weight indeed is the ideal weight for that patient. You can have, and in my experience, I had young patients with a great augmentation increase of the of a great increase of the interdialytic weight without great problems on lung ultrasound
Great. Exactly.
because they had a good heart. Probably
Yes.
it's my interpretation. Probably they had a good heart and they were in the first part of their dialytic story. But after a period of time, B lines appeared. Okay, so that interdialytic weight in the second part of their life was connected with the bilines, but
Yes.
not in the first part of their dialytic life. I don't know if I have clearly explained this concept. It's not so easy. So
Yes.
it's not so easy because lung ultrasound are connected with the two physiopathological aspects that I have explained. If you have one of them, of both, you have the augmentation of B lines. But it's not the rule. But if you have not a uremic lung or heart lung, you have a great heart. You can have not a great B line, so important B
Yes.
line. Okay.
An adaptation process, Pierpaolo, because maybe some patients, maybe they have an anuremic heart or a heart failure heart, but it is chronic, and the adaptation mechanisms provoke that they don't have a huge amount of B lines, you know?
Yes. Yes. Yes.
This is the important. So, well, there are a lot of questions in. Okay. Another person is questioning: is there evidence about the number of B lines and the specific amount of fluid overload? Maybe it's the same concept, no? Is there evidence about the number of B lines and the specific amount of fluid overload? I mean, a relation between B lines and fluid overload?
Yes, it's the same concept.
Uh-huh.
But in general, in, obviously, yes, in the sense that if you have an expansion of B lines, there is probably there is certainly an expansion of extravascular lung water. Okay, these two concepts are connected. But as I already said, it's not the rule that if you have an expansion, an increase in B lines, you have an expansion in total body water.
Right. Very nice. So there is another question, Pierpaolo. If you allow me, I know you it's very late for you in Italy. Sorry for this. Sorry. Well, maybe you are. Thank you so much. I really appreciate your attention. Another person is questioning. It says, "Buenas tardes. Mi nombre es Mari. Tengo dos preguntas. ¿Se usan todos los puntos mostrados para colocar el transductor para contar las líneas B o cuántos y cuáles puntos son los mejores para el conteo de las líneas B? Y la otra duda es, ¿cuál es el mejor transductor, lineal o convexo, para realizar el ultrasonido pulmonar? It is about basic questions, Pierpaolo, is about the technique. If you, how do you place the transducer in order to evaluate in a correct way the B lines? And the other question is, what is the best transducer for evaluate the lung?
But my answer is that the best transducer, the second question, which is the best transducer? You can use mainly the convex probe. If you are a cardiologist, probably you have a mini convex that is better. But with the convex probe, that is the one I have, I can make a good examination. So indeed, it's not so important the kind of probe. Probably with the convex, you can arrive in the deepest part of the lung, so your examination is better. With a convex or a mini convex, indeed. Perhaps the cardiological probe is the best. and a lot of studies are made with the cardiological probe. But you can use easily a convex. I use a convex because I have only a convex, and I say that probably the best probe is the probe you have. You
Yes.
have to use it. You have to make a to make a, while with a linear probe. You can use a linear probe, and it suggested some time. But indeed, it's more difficult to have a sufficient penetration to arrive to about 8 centimeters. That is the zone you have to arrive to see clearly the B lines moving on your screen. So the probe, as I said, every probe indeed is good, but mini convex is the best. Convex probe is good, and another important point, I have said this point, but I'd like to repeat, it's not important if you use harmonic or fundamental image. In every case, you have a good image. So it's not, this is not a problem. If you have an old machine without harmonic, it's good. You can use it for the lung ultrasound. And because we have said that is an examination of the artifacts. And about the first question, I don't remember. Pardon,
Yes,
Antonio.
yes, about the points to evaluate and to count the V lines, because maybe she has seen your article, and in your article you showed some points in the thorax. Exactly, this is the picture. Maybe he is mentioning that question regarding this picture.
Okay, I can suggest for this aspect a video you can find on YouTube by Dottoressa Gargani. You can search for lung ultrasound, and you'll find a sort of tutorial that is made in a very precise way by Dottoressa Gargani, and she explains well that you have to place the probe in the intercostal space on the parasternal line and hemiclavicular line on both left and right hemithorax. Obviously, on the left hemithorax, we can go only from from the second to the fourth intercostal space, while on the left hemithorax, we can go from the second to the fifth space. You have to find the second intercostal space when you visit your patient with the probe. You can see that under the clavicle there is the first intercostal space, and under the first intercostal space there is the second intercostal space where you have to place your probe, or you can use this zone. There is the connection of the manubrium of the sternum, because under it you have the second intercostal space. Obviously, you can also make your evaluation on the lateral side, and on this in this side you have the mid axillary and anterior axillary line on the right and left part of the thorax, and in this case too you have to consider that on the right part of the thorax you have four spaces to the second, from the second to the fifth intercostal space, while on the left you can go only from the second to the fourth, because there is the place of the heart.
Right. Very nice. Thank you, Pierpaolo. Thank you. And when there is another question, how many hemodialysis sessions do you need to treat 30 comet tails, 30 B lines in your experience, and approximately how many hemodialysis sessions do you need to treat a patient with pulmonary?
The question is about the 30 B lines.
30 B lines. Yes, 30 B lines.
Indeed, I think it's a good question, but it's quite impossible to answer to this kind of question, because we are talking about a pre-hemodialysis evaluation. So this is very important, because at the end, hemodialysis session, generally of these 30 B lines, probably there are less B lines. And as I already said, if at the end of the hemodialysis session I see that there are a lot of B lines, probably I am not in the correct dry weight. So what I have to do is to investigate my patients, combining the techniques. So I can use the bioimpedance and the lung ultrasound. If lung ultrasound confirms that there is a great number of B lines at the end of hemodialysis, for example, 30, and I have no confounding elements, just like pneumonia or other disease of the lung, probably I have to slow down my weight. And as I already said, probably I need a lot of time to go down. But if the patient is asymptomatic, because if the patient is symptomatic and I have to treat the patient in a more aggressive way, but in this case, I am not guided by the lung ultrasound because the patient is already symptomatic. So I have to end 1 or 2 dialytic sessions trying to solve the problem of the symptoms. If he has, for example, I try to answer to the question, it's not easy. At the end of the dialysis session, 30 B lines and the patient is asymptomatic, I have not hurry. I can go on evaluating the patients and slowly go down the dry weight.
Right. At the end, the clinical situation or the clinical condition is the main aspect.
Is the main fact? Yes. Okay. Ready? Right, Antonio.
Yes. Okay. Maybe we have to go slowly in case of the patient is asymptomatic, as you mentioned. Right.
You have. I would like to say to the audience, to the colleagues nephrologists above all, that you don't have to hurry. If you not have symptoms, you don't have to hurry. You have to study the patient. If you have to ask to yourself if you have done everything. If there are B lines, probably, if you have a moderate degree, the example of the colleagues for 30, but we can imagine another number, a more elevated number of B lines, and we have an asymptomatic patient, we have to reanalyze his dry weight. For that patient, probably we are not in the right condition. And we have to analyze again and try to tailor the ultrafiltration with B lines, but slowly. Because as I already said, in this case, we are not in a proven data. So we have to try this technique, but with attention, with a clear vision of the patient. If we have too slow, we have to slow down. We have to slow down the weight. We have to work slowly. Okay, this is very important.
Yes, thank you so much, Pierpaolo. And what about if the patient is, for instance, in the intensive care unit, and the patient is not able to speak and to mention his or her symptoms, and the patient is with an endotracheal tube, the patient is under mechanical ventilation, and you see in the lung ultrasound, you are watching B lines, but you don't know if the patient is symptomatic or asymptomatic. What to do in these cases, Pierpaolo?
But the patient is not asymptomatic, but you have a lot of other components, because if it's ventilated, obviously you have other problems. And if, for example, if you have the classic cardiorenal syndrome in intensive therapy, you can use B lines, obviously, but I have not found a lot of data on this setting of intensive therapy setting, because there are a lot of confounding elements. Right. I think that, for example, the ventilation itself is a problem, because B lines can be determined by this therapy. Exactly. And it's difficult for you to start a therapy tailored in a patient with this kind of machine. Right. And during, for example, if you make a continuous veno-venous hemofiltration in a acute kidney injury, intensive therapy, you can try to use lung ultrasound, but as I said, there are a lot of confounding elements, and I am not useful for this kind of setting, right? Honestly.
Yes, thank you.
I will be not so sure as I am in my chronic setting.
Right, thank you, Pierpaolo. I appreciate it. And there is there is one more question. An ultrafiltration less than 10 milliliters per kilo per hour is safe for the patient. With this amount, how many B lines I could reduce? ultrafiltration less than 10 milliliters per kilo per hour is safe for the patient with this amount of ultrafiltration. How many V lines I could reduce with this amount of ultrafiltration, I mean?
No, it's impossible to answer to this question in the sense that the reduction of B lines cannot be standardized. In the work I show you of just a moment if I find it, they found that there was a reduction of 2.7 B lines here for every 500 milliliters of volume removed here. Okay, but the ultrafiltration that the colleagues has underlined is that what we considered, so the 10 milliliters per kilo for hour is indeed the safe zone, what we consider the safe zone for the ultrafiltration. Obviously, we can go up, but it's not safe. And we know that from literature, there are a lot of data according to which it's good not to overcome the 10 milliliters per kilo per hour. Okay, right. So this is a general rule of the ultrafiltration. But how this ultrafiltration can be traduced in a reduction of B lines it's not for me possible to be said. I have only this work of Nobel in which there was a decrease 2.7 B lines for every 500 milliliters, but I have no other data.
Thank you so much, Pierpaolo. Well, apparently there are no more questions. Bueno, les agradezco a todos. Parece que no hay. Si alguien gusta hacer otra pregunta, este es el momento. Si alguien quisiera hablar y hacer una pregunta en vivo, lo pueden hacer. De otra manera, bueno, pues agradecerles a todos ustedes por habernos acompañado y en especial al doctor Pierpaolo. Como ustedes pueden ver, fue una gran sesión. Creo yo que estoy seguro más bien que muchos de ustedes le podrán obtener mucho provecho a esta sesión a medida que la puedan ir evaluando y la puedan ir viendo con calma, en forma lenta, como les comentaba a un principio, quizás en su casa, en el carro, con un proyector, en la televisión, en grande, etcétera. Creo que va a ser muy útil poder ir desmenuzando esta sesión poco a poco. Estoy seguro que para todos nosotros ha sido de gran utilidad. Pierpaolo, we are really excited for your nice presentation. Thank you. It was fantastic. There were a lot of participation. Thank you so much, Pierpaolo. We are really, really honored for your presence. Thank you for being part of this webinar. Thank you for your willingness. Sorry for the timing.
No problem.
Thank you, Pierpaolo, because I know it's late for you in Italy. We really appreciate it. I appreciate your attention and your participation. Do you want to say something for the audience, for the Mexican nephrologists? I think okay.
No, above all, thank you all for the patience, and I apologize for my English that is not so good. And first, and second, thank you again for your kind invitation. It was a pleasure, and I want only to leave a message for nephrologists, and because I speak to my friends, that I think that. We have, as a nephrologist, we have to use the ultrasound machine. We have to use lung ultrasound machine in hemodialysis. We have to be aware of the limitation of the techniques, but we have to start using this machine because it's easy, and we can have a good learning curve in a small period of time, but we can give the patient a real improvement in the quality of life. So we have to study the limitations of this technique. We have to be updated about what is said for this technique. From the question, I understood that there is a great interest for this technique, and I know that I have the same interest, I have the same passion for this technique, but we have to be aware of the limits, we have to study and to be updated. but finally, we have to use it. We have to use it. We have to use it for our patient.
Thank you, Pierpaolo. We have to use this powerful tool as you have mentioned in your papers and in your articles. Thank you so much, Pierpaolo. Well, do you think they can write an email for you if they want? Because you put in your slides at the beginning, your email address. I think they can send you questions for your email.
I have a special. How can I come back to the slides? I have the final slide with my email. That is just a moment. I'll try. Okay. Just a moment. Okay. I'll arrive.
Yes.
Here. Just a moment. I had here.
Yes.
You can see here my email. And if you want the PDF of this lesson, or if you have some question, or if you have something I have not explained in the right way, or something more, I'll be glad to answer if I can.
Yes.
So see you, and thank you all.
Thank you, Pierpaolo. Really, really appreciate it. Thank you so much. And see you maybe at the end of the year, maybe October, maybe November, with the next topic about the resistive index, if you agree.
Okay, will be a pleasure.
You are invited for the next webinar. Thank you so much, Pierpaolo. Have a very, very good night. Thank you so much for your participation. This webinar is over. Thank you so much. See you later. See you soon. Thank you so much, Pierpaolo. Bye.
See you soon.
Thank you. Thank you so much.